So I put up here some learning objectives to get through. It's going to focus on primarily 3 different things: review injuries unique to trauma and abusive trauma in infants, common patterns of brain injury associated with abuse, and to discuss a differential diagnosis. And in the last few slides, I'll discuss some potential advances in detection. And throughout the imaging protocol, I'll be showing some of the newer techniques, in particular arterial spin labeling is one of the techniques we find most useful. And I gave some CME questions that you can find, I guess, later on. So first of all, I'll start with the question: what is the diagnosis for this parenchymal injury? This is a month-and-a-half child that showed up to the emergency department with vomiting. So the possible choices they give you is arterial strokes, venous infarcts, cerebral contusions, or contusional tears. And hopefully all of you got that these are examples of contusional tears. And this is the reconstruction of the CT showing multiple fractures also in the parietal bone in this infant. So contusional tears have been around for a while. You can go back to 1969, finding some of the earliest reports. Right now there's a paper in the works, but there's very little in the current literature that describes these, and most of the imaging is poor quality MRI. They're also known as gliding contusions or contusional clefts. They're characteristics of blunt head trauma in infants, particularly less than 5 months, but you can see them up to over a year of age. It's thought to happen because there's little myelin, increased water, and a jello-like consistency of the brain with a very compliant skull. Shear stress causes these slit-like cavities to form in the white matter, and these are these cleft-like cavities. There's minimal hemorrhage and necrosis, but once you put on susceptibility radiated imaging or 2-2 gradient echo imaging, you can see a fair amount of hemorrhage associated with them, but that's not the predominant component. And they can be horizontal at the cortical tears that extend into the gyral crest. Subdural collections are a common association and may be associated with diffuse white matter injury. Interestingly, axonal shear strain, like you hear about in the older children, it's very rare in less than 5 months of age. So more commonly with those shear stresses, you're going to get contusional tears. Here's an example from an ultrasound, a coronal and a sagittal image. You can see these clefts in the parenchyma. The increased echogenicity here at the depths are small amounts of blood products. Also on this coronal ultrasound, you can see increased echogenicity in the corpus callosum from the shear injury in the corpus callosum. You could note too that those clefts had anechoic material in it, so not just looking like a CSF density. Here's the MRI done on the same day as the initial CT on the day of admission. So here's the CT, and on MR you can see that there's a diffuse increased T2 signal throughout the white matter, and you see these little tears in the white matter. Some have a little bit of hemorrhage around them and a tiny bit of ischemia, but for the most part, a lot of these clefts do not have have ischemia with them. So they may or may not have little areas of ischemic injury adjacent to it, and they have small amounts of hemorrhage that are best seen on the SWI associated with it. And in conjunction, you see those extraaxial collections, the subdural collections that Gary mentioned earlier, show that are hygromas, predominantly CSF and signal intensity, with just a little, most of the blood products being in the adjacent subarachnoid space. These can evolve over time, and it's good to know about the evolution. This child was fairly unstable during the course, so he remained in the hospital for 20 days. And you can see how these injuries evolve from the day of admission, 3 days later, 2 weeks later, and then almost a month later. You can see the extraaxial collections initially grow in size, and then we have these areas of CSF or parenchymal injury that evolved to become more CSF in their signal intensity. So areas that were clefts down here, you see growing of the clefts and essentially liquefaction of some of the areas of white matter. So throughout this time, there were no new diffusion signal abnormalities. So you see this evolution and sort of the liquefaction and almost dissolving of the brain without any additional ischemic injury features on the diffusion-weighted imaging. So this liquefaction actually is very poorly described in the literature as well, and I called a couple of pathologists to try to get more information, but there is very little description of this type of brain injury and evolution, and it's unique to the infant brain, unmyelinated brain. It's a tendency of the immature brain to liquefy without preceding necrosis. So now, don't be, so if you see this kind of injury evolving over time, it just can be the normal evolution of an immature white matter dissolving secondary to that initial injury. Now, this is an abstract that was presented by Gary and his team at ASNR in 2014, and I understand now that it's in press. Abusive, these contusional tears, as they're called, or lacerations, are much more commonly seen in abusive head trauma. And they looked at a number of cases over an 8-year span and found 18 lacerations in 137 cases of abuse and none in 27 accidental cases in the comparable age range. So think about, when you see these types of lacerations, think about abusive head trauma. It's usually thought to do, again, to those blunt impact, probably also somewhat related to the rotational injury that you get with the flexion extension and the shaking. Okay, next question. What are the findings on this scan here? We've got 4 choices: fracture and a subdural hematoma, subdural hematoma and ischemic injury, subdural and contusion, or subdural and hyperemia. So this is a subdural hematoma and ischemic injury. No fracture was identified on the CT scan. You can see sutures at the back and the lambdoid suture. This is, again, very similar and building on what Gary mentioned earlier. We see the subdural collection, a little bit heterogeneous, but in our experience, as Gary mentioned, when you see it associated with ischemic injury, it's most often acute in nature. Now, to see this ischemic injury, they can be very subtle. If you look at the right, you can see the sulci well-defined and the gray-white boundary nicely outlined, say, in the right frontal lobe, compared to the left frontal lobe, and you see that the subarachnoid space is a sulci face, and you can no longer see that linear band of the cortex. Similarly, if you look at the comparison posteriorly here, you see subtle low attenuation throughout the left side. Again, up higher, you can see that nice definition of the cortex here on the contralateral hemisphere. You're losing that definition of the gray-white junction. So look very closely, window and level narrowly, compare both sides. Look, when you see these subdurals in a case that you're concerned about, look very closely, because these ischemic injuries are very subtle when they first present and can be missed. So have a high index of suspicion and look very closely for that involvement. The history that we had when this child actually arrived at the emergency room was that she fell off a couch while the person in charge of the child was not watching. Here's some more images showing the coronal and sagittal reformations. And again, you can see the differences in the hemispheres. Nice subarachnoid spaces. That linear cortex can be well defined and differentiated from the white matter underneath. Whereas on the left side, you get sort of the hazy blurring and loss of distinction of that gray-white junction. In addition, you can see that there's this, a subgaleal hemorrhage collection and actually a cephalohematoma here. So abusive versus accidental trauma, the interhemic subdural hematoma is actually nonspecific, although we do see it, it's not 100% specific of abusive head injury. If it's heterogeneous, as Gary mentioned, it's more common abuse versus accidental trauma. So here we've got, again, that heterogeneous subdural hematoma, as Gary mentioned. In the population of 84 subjects prospectively studied, they looked at cases of abuse and accidental. So we had 54% were abuse and slightly less were accidental injury. And taking as gold standard those cases that were convicted for child abuse, these are the results that were shown in this paper here from 2010, is that brain ischemia was highly specific for abusive head injury. Subdural hematomas were sensitive, although not specific. And if you see the subdural hematoma with diffuse retinal hemorrhages and no scalp swelling, that it was highly specific for abuse. Now, one thing that actually you've got to be careful, nothing is 100%, of course, so this is due to numbers. And this was done, I believe, in the northeast region. And from what I understand, talking to Gary and other people in the Midwest, what they see in abuse is far different than what we see in Boston. We see more commonly the subtle cases of abuse, and in some parts of the country they get more obvious cases of abuse that are big skull fractures and clear, injuries due to hammers and other more aggressive types of injury to the child. We see more this type of injury here too, where there's often may or may not be soft tissue swelling, subtle parenchymal injury in the subdural. So these sensitivity and specificity are only relevant for the population that was studied, and there is a regional variability as to how these kids present. But the take-home point is here, when you see subdurals and ischemic injury, particularly in the setting of no soft tissue swelling, to be very concerned that this is a case of abuse. And don't let the lack of soft tissue swelling throw you off. And one of the famous cases, actually, that went to court, the lack of soft tissue swelling was thought to indicate that there was no evidence of abuse, and that's clearly not the case. Now, this same child went on for MR imaging, and this is the MRI scan on the same infant. You can see that there's diffuse increased cortical signal throughout the left hemisphere and also in the right frontal region. Spectroscopy confirmed a huge lactate peak and a decrease in the NAA when put over the region of the caudate, consistent with evolving ischemic injury or ischemic necrosis. Diffusion imaging confirmed diffuse involvement. This is done on the same day as this MRI, so the MRI can be much more obvious in terms of the degree and severity of the injury. On the arterial spin labeling, you can see that areas of involvement in the frontal and posterior region are already showing decreased flow, consistent with ischemic necrosis. A little higher up, again, you can see the increased T2 signal throughout the cortex. Subtle swelling, you can see the subarachnoid spaces are smaller on the left than on the right. And we see some vascular stasis on the susceptibility-weighted imaging with the blooming in the subarachnoid spaces. Low diffusion, lack of blood flow, and again, massive lactate with dropping metabolites as this brain is acutely going through ischemic necrosis. MRA confirmed no vascular etiology and actually decreased vascular supply on this side because of the dying brain tissue, that there's less demand, so the vessels are decreasing in size. So this actually brings up a question of what is causing these injuries. And there's, in the adult or young teen literature, there's a phenomenon called secondary impact syndrome. And these are mostly case series. There's one that was published back in 2010, the first one by Lisa Jean, had 10 cases. They had initial head injury with or without loss of consciousness that led to post-concussive symptoms, typically headaches. And a second hit, either direct or indirect, while still symptomatic, that could be hours to weeks after that first injury that led to a rapid decline. And these kids never had MR, but when they came in with CTs, they had thin subdurals and massive swelling. And when you put the cases that I just showed you adjacent here, oops, I'll show them here first, it makes you wonder whether in the cases that we see in our abusive head injury, whether repetitive injury may be playing a role. We know that abuse is not a one-time event. It probably occurs multiple times. It may be that the reason these kids are so devastated so quickly that they have underlying brain compromise and then get a second hit when they have that second injury. So it does complicate how we think of dating and timing the injuries. They probably do add on each other, but it does at least raise a suspicion of abuse. You may not be able to say exactly when, but that is up to the courts to sort out. What we need to do is make sure we are alerted to this pattern being highly concerning for abusive head injury. These typically evolve to fairly significant parenchymal volume loss. Another hypothesis for the asymmetric appearance of the CT scan is a trigeminal vascular hypothesis that came out in 2012. The trigeminal nerve innervates the dura and pia vessels, and that's actually why it's actually the only innervation to the dura, so the pain is often referred to behind the eye. The subdural hematoma is thought to irritate the dura, and since the dura also it innervates the PL vessels, it's thought to activate the trigeminal system, which then causes dilation of the PL vessels and unilateral swelling. Their argument is that the higher innervation of the dura in infancy with the trigeminal nerve results in exaggerated response to the subdural hematoma. So there's a mild injury, subdural hematoma occurs, it irritates the trigeminal nerve, which then dilates and also or activates and dilates the PL vessels, causing increased blood flow to that side, and that's the blood flow that's causing that unilateral swelling. But actually, if you look into the literature, the innervation actually is similar by adult by about 5 months of age, so that argument doesn't hold for very long. And swelling is often associated in our experience with ischemia, ischemic necrosis and edema. So I've never seen examples of hyperemia with swelling that didn't have also some kind of edema in the underlying tissue. It's the same thing that we see in evolution of stroke, too. In acute stroke, you don't see the swelling, but as the edema accumulates in tissue, that's when you get the swelling. So here's a couple example cases to make the point that are also in Paul Kleinman's book coming out. This one is a 12-year-old that had near drowning or near hanging, on day. This is day 3 after the event. You can see this is an arterial spin labeling sequence. You can see the increased blood flow through areas of the brain, also in areas where there's decreased diffusion. So it's a rebound hyperperfusion. But here we see that there's diffuse cerebral swelling due to edema and breakdown of the blood-brain barrier and leakage of fluid into the extracellular space. In comparison, this is a child with a febrile infection-related epilepsy syndrome that presented with seizures. You can see that there's massive hyperperfusion in this right hemisphere on the arterial spin labeling associated with some subtle or decrease in diffusion from the energy compromise, but we do not see any cerebral swelling because there's no edema or ischemic necrosis at this time. This is energy compromise. So until you start to see the edema on T2, you really don't see the swelling. So hyperemia alone, I don't think can cause that diarrhea swelling. And here's sort of a case where we have a marked hyperemia and no evidence of swelling, suggesting again that that's difficult to occur. The capillary system is only 6% of the blood volume. By vasodilating with injury, it isn't capable, I don't think, of giving a significant volume response. The other theory is a big black brain. Another thing it's called is big back brain. And the debate is this unique to the infant? Is this a secondary impact syndrome? And we really don't know. So this is where we're hoping that better imaging can help us unravel what the etiology of this hemispheric or sometimes this bilateral parenchymal injury can be. We know that it's not manifest from the subdural hematoma, and we rarely see this in accidental trauma, as others have pointed out too. So is it a combination of physiological stresses? And what Tina Duhaime has suggested, it may be a combination of hypoxia, hypotension, hypercarbia, and seizures combined together, causing metabolic stress to the tissue and ischemic necrosis. The trigeminal vascular response is still out there and in the literature a lot, but I think it's an unlikely etiology for what we see here, especially if you can confirm that the findings actually correspond with ischemic injury on diffusion imaging. So the last question, which is abusive head injury? I'll give you 1, 2, 3, 4, and 5 choices. And it's sometimes hard when you're giving a case cold and you don't have the history, but it's good to have a differential in mind when you approach these. So the right answer is this one here, and we'll go through each of the cases and discuss a differential diagnosis now. This was herpes simplex virus, urea cycle metabolic disorder, glutaric aciduria, and Menkes syndrome. So first, glutaric aciduria type 1. This is the most common thing you see in the differential. And at first I was confused as to why it was showing up so often, because you always have these abnormal signal in the acute phase in the basal ganglia when you have low ADC, and in the chronic phase you have the parenchymal volume loss and the big subarachnoid spaces. So why would that ever be confused for abusive head trauma? Well, it turns out that retinal hemorrhages can occur in these kids as well too. So I think that's why there's a confusion, is the retinal hemorrhages are seen, then the the big subarachnoid or subdural collections are seen, and abuse gets raised as a possibility. But I think any well-trained neuroradiologist or pediatric neuroradiologist would recognize the basal ganglia findings and the enlargement of the CSF spaces enter the temporal lobes that indicate that this is more likely to be glutaric aciduria, and that can be confirmed on testing. Herpes simplex virus encephalitis is something to be aware of. Again, this is a 12-month, a 13-month-old that presented to the emergency room with seizures and lethargy. That's a typical presentation of abusive head trauma as well as seizures and lethargy. And so when you see decreased diffusion, the history doesn't quite fit. Here we're seeing also thalamic changes that go along with seizure activity, and increased blood flow here is due to the seizure activity, and we're seeing involvement of cortical thalamic loops causing the changes here in the diffusion in the thalamus. So think about when you see diffusion abnormalities in the context of seizures, lethargy. If it's raised, think about herpes simplex. That's easy to confirm on CSF testing. In this case, the increased perfusion, again, is due to the seizure activity. Menkes disease, again, usually doesn't present like this initially. By the time they have the large subdural collections and you see this extensive parenchymal injury, the kinky hair is typically evident. Less than 3 months of age, 3 months of age, you may not have the kinky hair yet, but you don't have the big subdural collections yet either. The MRA can help confirm it by looking at the vascular tortuosity. Again, the presentation is very different. They lose their milestones. They present with truncal hypotonia. Blood can ooze into these collections because they get to be so big from the shrinking and volume loss of the brain, as Gary mentioned earlier. So the image by itself, maybe by an untrained person, could be mistaken for abuse, but when you get the history and look for other findings, I think it'd be rare that this could be truly mistaken for abusive head injury. And then finally, the sulfide oxidase deficiency. Again, the histories are very different in these kids. These ones present usually in the first few weeks of life. This presented on day 4. There's no hemorrhage, no fractures. Typically, there's no concerning history that goes with it. Subdural collections and hemorrhages are rare. We're seeing metabolic compromise of the entire gray matter, deep gray, and cortex without any sparing that is consistent with some of these severe urea cycle defects. Now, this is that abusive head case that I put in there in comparison. We have lots to help us understand that this is abusive head trauma. At admission, we're seeing some hemorrhage. We see parenchymal hemorrhage. We're seeing low attenuation, a subdural collection. By 16 hours later, it's evolving. 5 hours later, the subdural collections that are hygromas occur, which again would be atypical. This is not volume loss. This is a post-traumatic hygroma. So when this evolves over the stay, then, as Gary mentioned, you think about abusive trauma. And we're having diffuse parenchymal injury as well, too. Metaphyseal and multiple rib fractures were seen, and there's a suspicion of liver laceration. So lots in the history here. SWI, very helpful. We can actually see that some of these are little contusional clefts with hemorrhage within them. The diffusion involvement is pretty diffuse because of the severity of the injury, but you look again for other additional findings on the images to help, and as Michelle pointed out, seeing these subdural collections here in the upper posterior fossa extending into the upper cervical spine are very helpful, and this is why we do the sagittal FSEs or STIRs on all of our patients to look for these subtle subdural collections. And this child, unfortunately, went on to devastating injury. So the differential diagnosis, think about accidental, and we've talked about the differences of those above, infection, inborn errors in metabolism, including glutaric aciduria is the most common one that's mistaken. The other ones that I didn't show are mitochondrial and some of these newer channelopathies. These are the hemiplegic migraines, and again, unlikely to present in the infants. There are some other channelopathies that present with seizures in neonates and young infants, but they don't typically, and they can have diffusion abnormalities secondary to the seizures, but they don't come along with the subdural collections or the hemorrhages. So can we improve our ability to detect these abnormalities? These are two different children. This is a normal routine MRI in a 67-day-old that had visual tracking concerns but was normal in follow-up. There's a little bit of non-uniform signal from the surface coil that was used in this child, but the T2 and the diffusion-weighted imaging look normal. This is was read as a normal MRI at about 100 days, so close in age to this one, but there were multiple rib fractures of at least 2 ages, bruising in multiple regions, and here this linear skull fracture. So the MRI was performed to see if there's evidence of parenchymal brain injury. And again, the diffusion looks normal, the T2 weighted imaging looks normal. Well, we were actually benchmarking our arterial spleen labeling at that time, and I've color-coded it to give you an idea of the degree of blood flow. The mean perfusion in this child was about almost 30 milligrams per 100 gram per minute, whereas this one was almost 3 times that at 71 milligrams per milliliters per 100 gram per minute. So marked increased flow response. And interesting enough, I've seen one other case of this that was an incidental finding. A kid fell down a stair, had a fracture. We put on the ACL sequence and also saw increased blood flow. I don't know that it's specific to abusive head injury, but we see that I've seen it in a couple incidental or anecdotal cases of trauma. When we've been looking at the acute concussion kids that don't have parenchymal injuries that are 8 to 20, we're seeing cerebral blood flow actually correlating with their symptomatology, with higher blood flow correlating with higher symptoms. So I think this cerebral blood flow imaging may be very helpful as we move forward at detecting injury and maybe having another marker when the rest of the imaging is normal, this child might have taken a hit. The challenge right now is getting good quantitation and having good normative values to compare to. Another thing that's a potential to go into the field is the near-infrared spectroscopy approach. We've shown that with seizure activity, for example, due to hypoxic ischemic injury, the O2 sats may show a little difference, but CMRO2 goes up, and that's predominantly due to increases in blood flow. So increased neuronal activity due to the excitotoxic mechanisms of seizure in a hypoxic ischemic injury drives the metabolism up and drives up cerebral blood flow. And we can pick that up at the bedside with these little monitors put on the bed. The actual system that gives you the blood flow is just one of these. That's this system here called the diffuse correlation spectroscopy system. So even just this system in the emergency room may be helpful as a supplement to screen infants to see if there's any evidence of abnormal cerebral blood flow. Again, we need to get first more normative measures so we can have standard norm values and then to screen for concern for areas of increased blood flow. This is starting to get to the commercial area. Canon is creating a combined device with these different NIRS instruments that provide you automatic feedback on how good your signal is as well too. And because it is quantitative, there is a potential of getting normative data that we can compare to in the future. So when image, what do you do? CT versus MRI. I'll just go quickly through this. You'll have this in the handouts that I'll pass in just after I finish the talk. CT is still the first line for fractures, suspicious patterns of injury, and to make sure we identify surgical emergencies. MRI, we want to do in everybody, but as trying to be responsible about the use of MR, we do it when it's CT or it's positive, or if there's still neurological signs and symptoms in the presence of a negative MRI. And some of those subtle hemispheric parenchymal involvement we've got better at on CT because we did do the MRI when there were persistent symptoms. The protocol in the MR can be long. It depends what you want to prioritize. Obviously, your standard T1 and T2 and your blood products, DWI, to look for cytotoxic edema. MRS can be helpful to look for metabolic compromise. ASL is we've been testing out. It's now available on GE and also on Siemens, so at least so you can get an idea whether there's abnormal perfusion. And contrast may be helpful to look at venous patency and membranes, as Gary mentioned, for the membranes. And as Michelle mentioned, we'd love to do spine. We do sagittal fiesta at the cervical junction, and sagittal T1s to look for subdural collections, and then sagittal T2 for cord injury and subdural. And as the recent papers have shown, and Michelle has been showing, showing to us at our center, the more we do in the spine, the more we pick up those subtle subdural collections. So the reason we fight so hard to get the spine is we want to be able to make a definitive diagnosis. And so if we have suspicious findings but are hard to be 100% definitive based on the brain imaging, we don't have fractures, seeing the subdural hematomas layering in the spine adds another piece of information to make you more confident. But as Michelle suggested, it can be very difficult because these are kids who are in the ICU, and the ICU physicians, their primary concern is stabilizing the child. Our primary concern is answering the question to a certain extent. So we have slightly different points of view in terms of what we're trying to push, and especially understanding how to best treat them going forward. Having the sagittal T1 and T2, while there's blood products there, is very helpful because follow-up, they may disappear. So this brings up a big question too, in justification, like why do you do it? Do you do it for clinical management, for prognosis, to understand mechanisms, or for medical legal? And in some cases, more information ends up going to, getting the definitive or more definite diagnosis of abuse. There is limitations, obviously, because cost and availability. Not all sites can screen everybody with MR. So we really need to work together to develop consensus and come up with official guidelines of what we should be doing, because it's a little bit different than just clinical management. We need to provide enough information so that child does not go back to a risk environment. So ideally, I think we need to move to more multi-center studies so we can really prove what needs to be done in the future. So abusive head trauma is broad differential that must be entertained through clinical and imaging evaluation. Image early, consider both CT and MRI. Thorough testing, team of experts. If symptoms persist or worsen, repeat MRI. Follow up to assess extent of injury, because these do evolve over weeks. And we really need a team of experts to exclude other mechanisms. But there's still much we don't understand about the mechanisms of injury in the immature brain. And there's no trials actually right now. One of the neurosurgeons at our site is trying to get a trial a multi-site trial to treat these kids that have abusive head injury to try to improve their outcomes, like ApoE, which has been successful in the neonates, getting something to these kids experimentally so we can try to improve their outcomes. The CME questions, just you can look them up, but linear clefts and subcortical white matter, characteristic of blunt trauma in young infants. And the following combination is highly suspicious: ischemia subdural, especially in the context of no soft tissue swelling. And take-home points: recognize contusional tears in infants. If you've never seen them, you may think they're some kind of chronic sequela of a venous infarct or ischemic infarct. When you see the combination of subdural and ipsilateral ischemic injury, again, it's particularly if no soft tissue swelling, it's very concerning. DDX, get history, and work as a team. And again, MRI with SWI, DTI, consider additional techniques in spine imaging if the CT is abnormal. Thank you.
Thank you, Ellen, for that whirlwind tour